Welcome, everybody. So it is my pleasure to announce our speaker today. So Marmar Visegi is visiting us from UCLA. She's an invited Locke professor and a friend of mine. So Marmar directs the Clinical and Translational Research Program for the electrophysiology section at UCLA, and is sort of one of the rare triple threats. So a teacher, an educator, highly involved in the fellowship program, does top-notch varsity level electrophysiology at UCLA with complex ablation, and also does translational research in the animal world. And we're gonna hear a lot about her NIH-funded research involving the neuromodulation for arrhythmogenesis. Welcome, Marmar. Thanks for coming.
Thank you, Melissa. Wow, that was a great introduction. I'm not sure it was so deserving of it all. Good morning, ladies and gentlemen. Thank you for coming. I just wanted to thank Melissa, Rob, as well as Jeannie Poole for inviting me to come up here today. And then since I have so many slides, we're going to get started. So I wanted to talk a little bit about the challenges in ventricular arrhythmias and non-ischemic cardiomyopathy from an EP perspective, as well as potential therapies that we should be considering when those VT patients recur. I have no disclosures. So we're going to go through outcomes of catheter ablation in non-ischemic cardiomyopathy, the challenges of the substrate, the tools that we're currently trying to use and develop to improve outcomes, and then therapies that lie beyond catheter ablation. A few years ago, we kind of did an assessment of at least our volume to see if we were really ablating as many non-ischemic cardiomyopathy patients as we thought we were. And what we noticed is that at least in the Los Angeles area, over half of our VT ablation patients who were coming in referred for VT and structural heart disease were in patients with non-ischemic cardiomyopathy. And if you look at the literature, there's a ton of data on great success rates in ischemic cardiomyopathy. And so we wanted to see, okay, so we really are ablating as many of these patients, but what does that really mean for VT ablation outcomes? Because non-ischemic cardiomyopathy is a mixed bag. There's dilated cardiomyopathy, which is sort of an umbrella term that we use for patients with LV dilatation and LV systolic dysfunction. There's familial cardiomyopathies with lamin AC gene mutations and others, which actually have a high risk of VT. There is arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, myocarditis with presentation that can be very heterogeneous. Sarcoidosis, again, cardiac sarcoidosis has a high risk of VT, much more than dilated cardiomyopathy. And then, of course, in LA, we see a lot of Chagastic cardiomyopathy from the Hispanic population that comes up. So all of these different types of cardiomyopathies are put under the term of non-ischemic cardiomyopathy, but they really do represent different substrates. And if you look at traditionally what studies have shown since 2003, you'll notice that in non-ischemic cardiomyopathy patients, and these were initially smaller studies, the survival-free rate of VT, post-VT ablation, can range anywhere between 26% all the way out to 86%. And even in the latest multi-center study of 251 patients, they had a survival VT rate after one procedure of 52%. So why is there such a heterogeneity in this population? And why is it that in this Leipzig study from Germany, the non-ischemic cardiomyopathy patients had much worse cumulative VT-free survival rates as compared to the ischemic cardiomyopathy patients? So to basically answer some of those questions, a few years ago we put together the International Ventricular Tachycardia Collaborative Study, and this was basically a retrospective registry of 12 international and national centers, experienced VT ablation centers, to really look at outcomes in both ischemic and non-ischemic cardiomyopathy and try to figure out what led or what potentially predicted better outcomes in certain populations. And of this 2,063 patients that were in this registry, 46.9%, so about half, had non-ischemic cardiomyopathy. What we found is that potentially in a multi-center study, our non-ischemic VT ablation outcomes were a little bit better. So they were at about 70% at 1 year of follow-up, and the event-free rate was about 50 to 60% at 2 years of follow-up. So we were doing a little bit better, but it didn't necessarily explain some of the other things that we knew from other studies. We know that single center reports of catheter ablation patients in ARVC, for example, is phenomenal, right? Pre-ablation versus post-ablation median number of episodes goes down completely. There's a huge benefit when it comes to VT burden. And this is data from the Penn group, but at 5 years nearly of follow-up, 75% of patients with ARVC who present with VT are free after a VT ablation procedure of any VT or transplantation or VAD. And there is a significant reduction also in the number of antiarrhythmics used, particularly amiodarone. So this is sort of one success rate of one spectrum in non-ischemic cardiomyopathy. On the other hand, this multi-center study of lamin AC patients showed much more abysmal outcomes. So here, to really even accumulate these patients, you need multiple centers. So this was a multi-center study of 25 patients with lamin AC cardiomyopathy, but many of them required second, third, and fourth procedures. And despite all of this, at 7 months of follow-up, if you follow all the numbers, about half of them either required transplantation, VAD, or were dead, despite multiple VT ablation procedures and all those other options available to them. So we wanted to figure out what kind of drove the differences in outcomes, because dilated cardiomyopathy supposedly has an ablation outcome of VT-free success rate of 60%. ARVC seems to be about 80%, but ARVC patients are much younger. They don't have LV dysfunction, right? So is it the comorbidities that seem to be driving the better VT outcomes in certain populations, or is it the actual underlying substrate? So we took this database with about half non-ischemic cardiomyopathy patients, and we tried to look at their VT ablation outcomes. This was the unadjusted curves. So what you can immediately see is that ARVC and myocarditis have much better VT-free survival. This is the VT recurrence rate, so much lower VT recurrence rates than dilated cardiomyopathy, valvular cardiomyopathy, sarcoidosis, and hypertrophic cardiomyopathy. When we adjusted for the major comorbidities that we look at, really just two curves emerged. You had myocarditis, dilated cardiomyopathy, and ARVC here, with much lower VT recurrence rates at 2 years of follow-up. And then you had valvular, hypertrophic, and sarcoidosis, which much higher VT recurrent rates at follow-up. And this was true after you adjusted for their age, their gender, their ejection fraction, whether they had prior VT ablation, number of antiarrhythmics, and the number of induced VTs during their procedure, which is something that, obviously if you have more induced VTs, you're gonna have more VT recurrences. And these three types of cardiomyopathy kind of emerged as having much higher hazard ratios for VT recurrence after catheter ablation. So it seemed that not all non-ischemic cardiomyopathy patients were created equal, and the answer is why. If you go back to how we ablate patients for VT, the first mapping studies in non-ischemic cardiomyopathy patients suggested that these patients have the same mechanism for VT as the ischemic cardiomyopathy patients. So they tend to have reentrant circuits within scars, but they also, unlike the ischemic cardiomyopathy patients where this percentage is lower, tend to have much more focal triggered activity potentially as the cause of their VT. But armed with the knowledge that, okay, at least if we saw scars, we could find reentrant circuits and we could go and ablate the VT, we launched on. And we looked at our non-ischemic cardiomyopathy scars, and sure enough, in many of them, we could find these abnormal, late, sharp potentials, fractionated potentials that we associate with isthmuses for VTs, and areas of slow conduction that can serve as substrate for our VT circuits, and we could potentially go hunt them down. But what was different between our ischemic cardiomyopathy and non-ischemic cardiomyopathy populations is that for ischemic cardiomyopathy, we tended to find more of those scars on the endocardium. Whereas in non-ischemic cardiomyopathy patients, there was equal distribution between epicardial scars and endocardial scars. You were just as much more likely to find an epicardial scar in a non-ischemic cardiomyopathy patient as an endocardial scar, suggesting that that epicardial approach would be important for these patients. The other thing that we found is that these sort of late and very late potentials that we target for ablation in sinus rhythm tended to be more common in non-ischemic cardiomyopathy patients on the epicardium, but that in general, there was a lot less of them as compared to ischemic cardiomyopathy patients. And the reason this is important is because it is not common anymore to find a patient that you can put in VT and map in VT to find the focus for that circuit. Many of us now rely on substrate ablation. We rely on these very late electrograms and abnormal electrograms and fractional electrograms to target for ablation as potential substrates for VT. And so the fact that there's less of them in non-ischemic cardiomyopathy was a little discouraging. The other challenge of non-ischemic cardiomyopathy, and this became very apparent early on, is that these patients have scars in unusual locations. So they don't have these nice LAD infarcts that may be transmural or endocardial, subendocardial. They tend to harbor endocardial basal septal scars, so below the aortic valve, like kind of where all your conduction system is sitting. Or they tended to harbor these epicardial basal lateral scars, right? And these endocardial substrates weren't sort of in this nice endocardial, subendocardial distribution of ischemic cardiomyopathy. They tend to have these areas of sort of striae-like fibrosis within the myocardium that can serve as a substrate for VT. And these, as you can imagine, are much harder to target than a nice subendocardial scar for VT ablation. And in fact, people did studies, and they showed that if you had this anteroseptal scar, you were more likely to have recurrence of VT than if you had this infralateral epicardial scar. The other problem we saw in non-ischemic cardiomyopathy is a lot of intramural diffuse substrate. So maybe you could get a potentially almost normal voltage map on the epi and on the endo, but within the myocardium is where all the scarring and the diffuse fibrosis lay. Again, if you're ablating from surfaces, potentially harder to get to. And there was an MRI study that looked to see sort of if where your scar was predicted how well you did when it came to VT recurrence and ICD shocks. And indeed, if you had this mid-wall, mid-myocardial scar, you tended to do worse than if you did not have a mid-myocardial substrate on MRI. To really sort of put the nail in the coffin, what we noticed is that many of the fractionated late potentials that we target for ablation occur in transmural scars. And that in non-ischemic cardiomyopathy, where we have more patchy scars, those targets are just less. And so harder to find, less ablation can be done unless you put the patient in VT and potentially have them on ECMO while you map in VT. Finally, when you looked at these patients with valvular cardiomyopathy or those with these basal lateral epicardial substrate on growth pathology, this is what you saw. Fibro, fatty covering of myocardium. And indeed, these regions at the basal lateral ventricle are hard to get to. There is a huge layer of fat. The coronaries all lie here, right? Making it, again, difficult to really target the underlying myocardium. And when you even look at CT data, what you find is that if you include the fat and the myocardium in these regions, you're trying to burn through 16 millimeters of tissue to potentially get through areas to target at the basal epicardial or basal mid-myocardial lateral wall, fat and myocardium combined. So it seemed like, okay, so the location of the scar seems to predict what happens in patients with non-ischemic cardiomyopathy, but is that related to etiology? And this was a really nice review done by Katja Zeppenfeld and Jack in 2018, where she kind of shows you where different non-ischemic cardiomyopathy types tend to present with their scars. So laminopathies have a much higher percentage of these basal septal scars. Cardiac sarcoidosis the same, whereas Trigassa cardiomyopathy has nice epicardial scar distribution. Myocarditis tends to be more heterogeneous, but again, a more predominant epicardial scar, regions that you could potentially access for ablation. So what do? Do we just give up? I think that at least at our center, a pre-procedure MRI is really important in figuring out and also discussing outcomes of VT ablation with your patients, because, you know, here, you not only can give them an idea of what their VT recurrence is, but you can also give them an idea, or you give yourself an idea what tools you will need that day as you head into the VT ablation lab. And so, whether their scar is this mid-myocardial scar or a subendocardial scar could really determine how well they do and how well you do in the lab that day. The other thing that we did and found out very quickly is that many of our non-ischemic idiopathic patients had positive PETs. Who presented with VT. So we basically did a study where we took 103 patients that had presented to our center with VT under the umbrella of non-ischemic cardiomyopathy. And other etiologies had been ruled out, so they were called idiopathic, so they didn't have HOCM. They had all had genetic studies showing they didn't have lamin AC cardiomyopathy, potentially. Their trypanosoma cruzi titers were negative. And so this sort of idiopathic non-ischemic cardiomyopathy presenting with VT, we started doing consecutive PETs on them, basically. And in this study of 103 patients who underwent PET scanning as well as MRI, who had no other evidence of other types of cardiomyopathy that we could see, nearly half of them had an abnormal PET. That was pretty striking to us. Nearly half the patients that were sold to us as sort of this idiopathic non-ischemic cardiomyopathy actually had an abnormal PET. And when we kind of broke them down into systemic inflammation versus localized inflammations and then treated them with immunosuppressives first, and then a combination of immunosuppressives and ablation if they recurred, what we found is that if they were in the early stage group, the early stage group was the group that didn't have scar on MRI yet and did not have perfusion defects on PET, their success rates, freedom from VT, was much better, 71 and 75%, versus those who were late stage, who already had evidence of scar on their PETs, suggesting that if you get a patient with non-ischemic cardiomyopathy that presents with VT, potentially you would want to get a PET and treat with immunosuppressives before you take them to the lab. And this was actually something the Japanese group looked at in 2014. They only had 37 patients with cardiac sarcoidosis and sustained VT. And they took 23 of them, or they treated all of them with immunosuppressive. 23 of them actually had no recurrence of sustained VT just after immunosuppressive medications. And the 14 that had recurrences and were taken for VT ablation, 8 of them had no recurrence of their sustained VT. So with the combined approach of immunosuppressive plus VT ablation, you could get potentially an 83% VT-free survival rate, which is much better than what I quoted to you in our studies where we were just doing VT ablation after VT ablation for the cardiac sarcoidosis patient. The other approach is, electrophysiologists can be very creative. I kind of say there's no place in the heart that we can't get to. So we and our colleagues have done a number of other things to try to get to that septal substrate. And one of the things we like to do is to see if there is a septal branch of the LAD, for example, that will guide us down to a region that we need to get to figure out if our site is a circuit for VT. And so we, wire our LAD and wire a septal branch. And if we find sites that are early for our VT, we can actually coil embolize it, for example, and get rid of that potential circuit for VT. There's reports of venous alcohol ablation where you can use your BMW wire to get into the coronary's venous branches, find potential small perforators that could lead to your VT circuit site, map in that region, and then inflate a balloon and inject alcohol into that small perforator to be able to get rid of that VT circuit. So we can be creative, and the truth of the matter is that there's a lot of potential technologies coming along. There's irrigated needles. There is the Sphere 9 catheter, which can apparently ablate up to 22 millimeters of tissue. And many of us, including us at UCLA, are using bipolar ablation, where we put our active ablation catheter on one side of the septum, we put another ablation catheter on the other side of the septum, basically rig the other catheter to serve as ground, and now do bipolar ablation between the active catheter and the ground catheter, and create much larger regions to be able to access that mid-myocardial substrate. But, to me, this seems like, okay, so we're just developing bigger and bigger nuclear weapons, right, to wipe out more and more tissue. And as you can imagine, all of these things are going to have collateral damage, whether it's to coronaries or whether creating more scar and substrate for the future, or whether it's, tamponade and pericarditis. So what do we do? So I'd like to spend the rest of this talk potentially talking to you and convincing you that the world of the heart is not all about the muscle. and that in reality, VT and VF is, a combination of a heterogeneous substrate, a normal heart that becomes diseased with scar and fibrosis, and dynamic modulation of that substrate by the autonomic nervous system that actually causes VTVF. And so it surely shouldn't be a surprise that many of the therapies that we use for heart failure, beta blockers, ACE inhibitors, aldosterone, statins, and CRT, actually also target the autonomic nervous system and seem to reduce sudden cardiac death in cardiomyopathy. So I like to show this picture because this is a cleared mouse heart. And this is just a PGP 9.5 pan-neuronal marker. And what you can see is once you clear the tissue, the heart is densely innervated. There are thousands and thousands and thousands of nerve fibers on the heart. Every piece of tissue, every myocyte receives innervation. And these fibers are sympathetic and efferent, parasympathetic and efferent, but many of them are afferent fibers, taking information away from the heart to the neurons on the heart, the little brain on the heart, as well as the sympathetic and the parasympathetic ganglia, the spinal cord, and the brainstem. So just a quick sort of review refresher from medical school. The primary sympathetic innervation to the heart starts at the stellate T1, T2, T3, T4 thoracic ganglia. These are post-ganglionic sympathetic fibers that emerge from these ganglia and directly land onto the atrial ventricular myocardium. The parasympathetic preganglionic fibers come down the branch of the vagus, and they synapse onto the neurons of the heart, and they tend to provide then those neurons post-ganglionic parasympathetic innervation to the heart. But I think it's really important that at each of these processing levels, whether it's the intrinsic cardiac nervous system, whether it's the stellate ganglion, whether it's the spinal cord or the brainstem, there's information that is being received by these neurons. That's afferent neurotransmission that modulates the efferent outflow to the heart. Okay, so what does that all mean for, VT? So for the most part, many of the sympathetic blockade procedures tend to focus on the stellate ganglion, right? But I want to point out one small thing, which is that the middle cervical ganglion, which lies just superior to the stellate, sort of just above the subclavian, actually provides a great deal of cardiac innervation as well. So that any procedure that cuts this and takes this away actually still leaves quite a bit of sympathetic innervation intact, okay? So we're electrophysiologists. We love to map. We can put electrodes on any heart, mouse, pig, human. And using these electrodes, we can look and see what the effects of sympathetic stimulation, for example, does. And in this case, I'm showing you a pig heart. We can put a sock electrode on it. We can look and see where those electrode locations are using these nice polar maps. And then we can do different modulations. And from these electrical sort of unipolar electrograms, we can measure something called ARI, or activation recovery interval, which for all intents and purposes is really just a surrogate of the local APD of that regional localized myocardium. And there's pretty good correlation with local APD 90 and ARI on the ventricular myocardium with different diastolic intervals, so that now we can do sympathetic stimulation and see how the ventricular myocardium and the APD action potential duration changes. And so what I have here is these baseline polar maps and bilateral stellate ganglion stimulation and bilateral middle cervical ganglion stimulation. And you can see that whether you stimulate the middle cervical ganglion or the stellate ganglion, you will get nice reduction in action potential duration, and that the effects are equivalent. So you can't say that just because you took out the stellate or blocked it, that you have interrupted all sympathetic innervation to the heart. There is middle cervical ganglion innervation remains completely intact in that scenario. But it is true that right and left stellate stimulation do seem to be correlated with causing badness in the heart. So this is a study where we looked at normalized dispersion of repolarization. How much heterogeneity in action potential duration does nerve stimulation cause? And we all knew that T-peak TN is a potentially independent surrogate of sudden cardiac death in patients post-MI. And we found that there's actually a good correlation during left stellate and right stellate ganglion stimulation with normalized dispersional repolarization and normalized T-peak TN interval. and that whether you stimulated the left stellate or the right stellate or the bilateral stellate ganglia, you got increases in dispersion of repolarization, in heterogeneity and action potential duration that could serve and now persist the substrate for VT, the reentrance circuit that is needed for VT. The other striking thing was that with norepinephrine infusion or isoprosternol infusion, you didn't get the same dispersion of repolarization, right? So the nerves were much more powerful at creating heterogeneities, and you can see that by just looking at these polar maps in the different colors, than norepinephrine infusion, for example. But wait, so nerve stimulation causes heterogeneity and action potential duration, but everybody knows from MIBIC studies and PET studies that the scar is denervated. So what am I sitting up here talking about? There are no nerves in the heart. And it is true that multiple MIBIC and PET studies have shown that the scar does become denervated, whether it's ischemic cardiomyopathy or non-ischemic cardiomyopathy. And the greater the amount of denervation that you have of sympathetic nerve fibers, the higher the risk of sudden cardiac death. So what are we doing? How do we put these two theories together? And I just want to point out this study, which was done by Mike Fischbein and Peng Chen a long time ago at our center, where they took transplanted hearts and they looked to see what the regions around the scar looked like in terms of sympathetic nerve innervation. And they described this sort of increased innervation at the border zone. Now, here's the thing, the caveat of this increased innervation at the border zone. It is not everywhere in the border zone. These are peripheral nerves trying to grow back into the scar. It's small, localized regions. So you have a scar that's denervated. You have small, localized regions with hyperinnervation. It's not really hyperinnervated. It's just that that area has innervation and the rest does not. So you can't necessarily say that it's hyperinnervated. But the idea is that sympathetic nerve fibers actually try to grow back into the scar, but are unable to basically provide the same normalized reinnervation post-myocardial infarction. And there's data from Beth Habeker's group that I don't have time to present today at OHSU that basically shows that if you could promote normalized reinnervation after myocardial injury by prohibiting the proteoglycans that inhibit the normalized reinnervation, you could potentially reduce the risk of VT. So what happens in the setting of scar, the combination of the denervation, the localized reinnervation of nerve fibers trying to grow back, is really what seems to make it even worse than what you would have as sympathetic stimulation in a normal heart. More heterogeneity now than you had to start with. And we did this by looking at human scars in patients who were growing VT ablation. And we couldn't at that time directly stimulate their sympathetic nerve, so we put up our catheters over normal border zone and scar regions, and again did our unipolar ARI recordings. And what we found is that normal sites behaved very differently with nitroprusside than border zone regions versus scars. In fact, these sites tended to be more denervated. The border zones seemed to respond a bit better, but even there were normal sites around our scar, the viable sites, that seemed to be denervated. So if you get a huge surge of sympathetic stimulation and you have a heart that seems to respond differently in different regions, even beyond what normal innervation of sympathetic nerves does, then you've really set up sort of the heterogeneity that you need to create a substrate for functional VTs, where you have different regions with different action potential durations and repolarization times that can help promote a circuit for ventricular arrhythmias. But lo and behold, the amount of cardiac remodeling that occurs in the heart, the neural remodeling that occurs to the heart, is not localized to the heart. And this study was done by Olu, one of our fellows at the time, who's now on faculty. But basically what he showed is that the changes that you saw in the neurons of the stellate ganglia in patients with normal hearts, ischemic cardiomyopathy, and non-ischemic cardiomyopathy. So we had normal ganglia that we collected from one legacy. And then we had our ischemic and non-ischemic cardiomyopathy patients that were undergoing cardiac sympathetic denervation. We looked at those neurons. That their non-ischemic cardiomyopathy patients actually have even more remodeling of their stellate ganglia than even the ischemic cardiomyopathy patients. And remember what I said was it seems like triggered activity is a bigger mechanism for VT in these patients, suggesting that if we could maybe interrupt some of these pathways or maybe give them a nudge in the right direction, we could be even more helpful in patients with non-ischemic cardiomyopathy. So basically, whether you have myocardial infarction or myocardial injury, you get a whole series of cytokines and neural growth factor that are produced. This tries to cause nerve sprouts and reinnervation back into the scar, but the scar actually produces molecules and proteoglycans that prevent normal reinnervation. And you have stellate ganglion remodeling, and now we know you actually have remodeling of the inferior vagal ganglia or remodeling of the intrinsic cardiac ganglia all the way up to the brain, that in the setting of sympathetic activation, as you're running to the airport to catch your plane, you can have both EADs and DADs that are created, but now an increase in the dispersion of repolarization, an increase in heterogeneity and action potential duration that can put you into VTVF. And what we found is in our pig model that had infarcts, that when you did cardiac sympathetic denervation, you could potentially get rid of some of these functional circuits. So this is sort of activation time. And what is activated late is shown in red, and what is activated early is shown in blue. And here we're pacing from border zone and scar regions. And what you can see is the activation, right, is kind of blocked by this region and then tends to go around it, right? And that post-cardiac sympathetic denervation, when you take out the lower half of the stellate T2, T3, T4 ganglia, that region is just not there anymore. The other interesting thing we found in some of the pigs was that when you did stellate via metacervical ganglion stimulation now, you could see again these areas that seem to be functional areas of block, and that post-sympathectomy, middle cervical ganglion stimulation no longer had that change. And so it seemed like you had altered the substrate in a way that potentially you could decrease the functional VTs, and in fact, post-cystelectomy, VT inducibly went down in these animals. So many of the strategies for neuraxial modulation of ventricular tachyarrhythmias have now, based on sort of a lot of the data that is in the literature as well as some that I've mentioned today, rely on either decreasing sympathetic drive or increasing parasympathetic drive. And there's multitude of pathways that we can use to decrease sympathetic drive, whether it's thoracic epidural anesthesia, stellate ganglion blockade, cardiac sympathetic denervation, renal denervation, and multitude of pathways that are being used to try to increase parasympathetic drive. And I won't have a chance to talk a lot about the parasympathetic stuff today, but not to mention that my one caveat with parasympathetic stimulation, all of these electrical stimulation of nerves, is that you really have to do the studies to do them right, figure out what parameters, what dosing, what you need to use in order to get optimal effects and reduce side effects. But I will talk about cardiac sympathetic denervation today because we really found that this helped us in that patient who was now going for the third VT ablation, right, or the fourth VT ablation. And really, their EF was like 40%, otherwise they were fine. So we didn't want to send them yet for transplant. Well, we did want to give them an option to treat their VT. And cardiac sympathetic denervation at our center is done through a VATS approach. This is actually how it's done in most centers now throughout the United States. We remove the lower half to 1/3 of the stellate and T2, T4 thoracic ganglia. The approximate OR time can actually, this says 60 minutes total, but it can actually range up to 3 to 4 hours if you're doing just the left side or bilaterally. And recently, since we're doing bilateral, it's really 60 minutes on each side. And the chest tubes go in and come out in about 24 hours. But what we do is we do single lung inflation. We deflate, let's say, the left lung, and we're trying to take out the left sympathetic chain. And we cut the parietal pleura, and we basically isolate the stellate ganglion, T2, T3, and T4 ganglia. And we cut at the sort of the half to 1/3 and remove this entire chain. We make sure that we do some sort of histology, frozen sections at the time, so that we can be assured that we actually removed neurons and not fat, because I can tell you, having been in these cases, sometimes that's hard to distinguish. And so we look to see what happened to our patients who had left and bilateral cervicothoracic sympathectomy for recurrent VT at follow-up. And this was initially just a single center study. And, most of them were male. About 54% had non-ischemic cardiomyopathy. They had a whole host of different types of VT. Some had monomorphic VT, a lot had polymorphic VT, and there was sort of a mixed bag of etiologies here. So it wasn't like, oh, we only picked the dilated cardiomyopathy patient. Their ejection fractions were low, about 30%, and they had all had about 2 previous VT ablations. That was the medium number. Some of them that just had idiopathic VF had no other, were not attempted for VT ablation. And what we found is that at 1 year of follow-up, about 50 to 60% of our patients were VT free. These are patients that had presented with VT storm and refractory VT. They were very sick. Basically, their only other option at that point was to say, okay, here's your transplanted heart if you qualify. And so the fact that a year later they had not had a single episode of ICD shock was surprising. And in this small cohort, the bilateral group seemed to do better than the left-sided only. And I showed you how both the right and the left can increase dispersion or repolarization and cause heterogeneity in scarred regions of the heart. So what were the complications? Well, acutely, we had 2 patients that had hemothorax, 1 patient that had pneumothorax, and 3 had mild ptosis on the left side. The left tends to be harder to take out than the right, stellate. And at 3 months, or greater than 3 months, about 5 of the patients felt like their skin sensation was not normal. It's not that they couldn't feel, but that they felt like that they had increased sensitivity. 4 of them had a change in their sweating pattern, so not surprisingly, they didn't sweat in their chest and upper arms anymore because the neurons of the sweat glands from the upper chest and the arms are also sitting in the stellate T2, T3, T4 ganglia. And only 1 patient, though, still had what was called mild ptosis by her husband. So that's a single center small study. And what we wanted to do was to look at all the sites that were doing this procedure, pool their data, and figure out how these patients really did post-cardiac sympathetic denervation. And so this was a study of 5 centers that was put together. 2 of them, one was in India, the other was in Colombia. That's where doing those are the people that are the surgeons that are doing those procedures. And we had 121 patients that we were able to get back in 2016 with sort of 1 year of follow-up to look and see how they did. And again, these were sicker patients. Their EFs was about 30%. The majority actually had non-ischemic cardiomyopathy, so 27% had ischemic cardiomyopathy. The median number of ICD shocks in the 6 months prior to this procedure was 10. And 75% had either a history or presentation with VT storm. And you can see that they had, a lot of them had more than 1 VT morphology. About 40% had polymorphic VT in addition to monomorphic VT. So really just a lot of things that as an electrophysiologist you look at, you're like, oh my God, this is going to be a long day in the VT lab and I may have to come back again tomorrow. So what were the outcomes? So reassuringly, at 1 year, right, about 58% of the patients were VT ICD shock and transplant free. So median number of 10 ICD shocks 6 months prior to the procedure. Nearly 60% have not had an ICD shock a year after. And there was a considerable reduction in the number of ICD shocks in the 6 months prior as compared to the year after the procedure. That was very reassuring. The other thing that was reassuring is that it didn't matter what type of cardiomyopathy you had. That when it came to neural remodeling, the ischemic and the non-ischemic cardiomyopathy seemed to behave the same, and it had similar VT ICD shock-free, transplant-free survival rates. And finally, even in this cohort, because we still had a few surgeons at some sites that really insisted on doing left no matter what, and we didn't have enough data to convince them otherwise at the time, that bilateral still did better. That the VT ICD shock-free survival rate was still better in the bilateral CSD group as compared to the left-sided only group. So what were the factors that seemed to make the patients recur after cardiac sympathetic denervation? And this was very striking. If you came in with an NYHA class 4 and you were already on your pressors, you did much worse after cardiac sympathetic denervation than if you were that NYHA class 1 or 2 patient. So already suggesting that at certain disease states, if you consider this too late, it might really be too late. And the other factors that seem to contribute potentially to recurrence after cardiac sympathetic denervation, other than NYHA class 4, and there was sort of you can see this trend, right? As NYHA class increases, the hazard ratios for recurrence after cardiac sympathetic denervation goes up, was VT cycle length. So, at our center, we tend to not do this procedure anymore for patients who come in with very slow VTs, 120, 130 beats per minute. Because for whatever reason, it seems that the faster sort of maybe sympathetically driven VTs respond very well with this procedure. But as the VT cycle length increases and the rate of the VT slows, and often in those patients, you're just dealing with sort of humongous scars, right? That this procedure may not be as beneficial. This study wasn't really big enough to kind of address the question of, well, does Chagastic cardiomyopathy do better than sarcoidosis? But sort of we are putting together a prospective registry of international cardiac sympathetic denervation and looking to see if we can get some data over the next couple of years. But some centers have kind of already published their small case series. This was just a study of like 7 patients where they looked to see at the number of ICD shocks pre-CST versus post-CST for sarcoidosis patients in this particular case. And they noted that there was a good reduction in the number of ICD shocks. And we looked at our Chagastic cardiomyopathy data earlier with this Columbia group, and we found that Chagastic cardiomyopathy actually also seems to benefit from this procedure with a considerable reduction in the number of ICD shocks and ATPs post-procedure as compared to pre-CST. But really, the question of etiology requires much bigger databases and potentially prospective studies, and we're working on that now. But for now, what I can tell you is the non-ischemics benefit as much as the ischemics, and that this does tend to have an effect on helping the substrate when it comes to the more difficult substrates with the septal VTs or the valvular cardiomyopathies with the very basal lateral scars. The other potential, I have a little bit of time thing that I'm kind of going to rush through, and this is something else we'll be doing for treatment of VT, is actually renal denervation. So for a lot of the refractory VT patients that come in, what we've tried to see is if we can reduce their sympathetic denervation using renal denervation. You can usually do it in the same procedure using the same ablation catheter. And we combined our data with Dr. Dickfeld's group in Maryland to see how these patients did. And again, this was a small series. You put your ablation catheter in the renal artery. You're trying to stay more proximal than the distal branches. And for our center, what we do is we actually stimulate the nerves, look at the blood pressure response, and then we ablate, stimulate again to see if we have a lower response, sort of as a gauge potentially for an endpoint. But all of that, obviously, in this particular field still needs to be worked out. But what we noted in these patients is after renal denervation, there was a considerable reduction in their VT episodes. So autonomic modulation, sympathetic stimulation really does play a role in creating VTVF, and we can keep beating the substrate as much as we want. But at the end of the day, there's really a huge spectrum of pathology that occurs with the scar that we're not addressing if we only focus on the myocardium. So this was actually a bigger study that looked at renal denervation in patients from a South American group, and most of these patients had Chagastic cardiomyopathy, but some of them had the non-ischemic dilated cardiomyopathy group, and they also have shown a considerable reduction in VTVF ICD shocks episode and ATP episodes with renal denervation. These are still smaller numbers of patients, but sort of worth thinking about and considering if you have that refractory VTVF patient. There is a problem with renal denervation, and the problem with renal denervation right now is that the periarterial anatomy varies. And actually, most of the nerves, the density of the nerves tends to be more distally than proximally, and distally is where we try to avoid because we don't want to cause dissections or problems with renal perfusion. The other problem with renal denervation is that we don't know at the time that we're ablating what sort of our arterial microanatomy is, what other structures other than nerves are surrounding our renal artery. And whether there is a lymph node nearby or whether there is a blood vessel nearby, your ablation lesion can look different. The blood vessel has a cooling effect. The lymph node tends to draw the heat towards it. And so getting sort of a homogeneous ablation in an area that you're targeting can be difficult and needs to be worked out. But I think the major problem with the renal denervation field at this time, is that we really need better endpoints. When do you stop? When is your renal denervation over? And so you can say, okay, you're done. And I think that was a major problem also with the Symplicity trials. The last one, where, if I'm in there and I'm using my ablation catheter to ablate, when am I done? And that's when we started using sort of that hypertension response as an endpoint, but that's a very gross endpoint. Still a lot of work needs to be done. So in summary, VT ablation and non-ischemic cardiomyopathy can reduce burden of VT and increase VT-free survival. However, outcomes are driven by etiology and location of scar, and pre-procedure workup, whether it's MRI or PET or genetic testing, is really key in determining your success. Novel ablation tools are becoming rapidly available to address this more challenging substrate, mainly aimed at bigger, Let's go bigger for our ablation lesions. But currently, that can also have downsides. And so it's really important to look at therapies beyond catheter ablation and target potentially the autonomic nervous system as an important avenue for treatment of refractory VT. Thank you.
That was a great talk, Mama. I'll take some questions. Jeannie?
Yeah, it was great. Really fun to listen to everything that's going on in this field. Like a lot of things in cardiology, high medicine in general, old things come back once the methodologies are improved to be able to understand what we're doing. You know, Doug's really sort of established the post-infarct model with innervation in the morning.
Absolutely.
Heterogeneity of nerve regrowth in a sense. Now fast forward several decades with the work you're doing and others, it's really interesting that we can think about targeting these sick arrhythmia patients in novel methods. So the question I would have for you is, do you think that stellate ganglionectomy will be earlier in the pipeline of therapies in certain patient groups, or even in countries that don't have a lot of, really trained VT ablation labs?
So I can already tell you that one of our investigators in India, who is part of the ICSD study, now doesn't want to treat his VT patients with VT ablation, tends to send them for sympathectomy first. So it is, and certainly in those countries where VT ablation is an expensive resource, where those resources are not as readily available, this should be considered first. I also think that based on just even the limited data that we have, you shouldn't wait till your patient is on their deathbed in the CCU, where kind of you've tried everything and everything has failed, and then send them for a surgical procedure. You really should try to target it early, and that's really kind of what we're trying to do. If we are offering this procedure to our patients now after their first failed VT ablation, whereas before it used to be like, okay, here's a second, here's a third, here's the fourth, and let's see how you do.
Is that in ischemics and non-ischemics?
So our population is a little bit different. Most of our ischemics have had a previous endocardial ablation elsewhere. So we do try the epi and the endo. Most of our non-ischemics also have a previous endocardial ablation elsewhere. So we do still take them for at least one what we consider to be comprehensive epi-endo procedure. And if, we're looking at just, tons of VTs, and at the end of the procedure, they're still inducible for VT, it's time to start the conversation. Not necessarily to be like, tomorrow we're going to take you for a sympathectomy, because a lot of patients aren't necessarily ready to have yet another surgical procedure after their long VT ablation procedure. But to be like, look, we did this, you still have other VTs that are inducible, this is something you might want to consider. And we try to do it earlier, before they come in with their incessant VT and VT storm.
Rob.
That was a great talk, Marmara. It's really nice to see how it's evolved over time, so congratulations.
Thank you.
On that. I'm going to be a contrarian now, just for a second.
No, not you, Rob, never.
So the study you showed us on bilateral and left stellate, that was in combination with the VT ablation.
Almost all of them had had a previous VT ablation.
So the strongest data that's out there is a study not just of stellate ganglion removal, but it is subsequent VT ablation.
No, previous VT ablation.
Previous,
Yeah.
but also at the
Yes.
time. And
Yes.
it's arguably the sites that they were ablated at were all the best places other than the University of Washington. Other than that. So my question is, you then said in response to Jeannie's question that this should be an option even before VT ablation. Where are we with a randomized clinical trial, and do you believe the data? You obviously do, but maybe explain to me why the data is strong enough to make this recommendation.
We are currently in a randomized trial in a status where we're trying to create a trial that looks at patients who have a recurrent ICD shock or are inducible post-VT ablation. So VT ablation is still the standard of care for all patients with structural heart disease that are presenting with VTVF, right? So what I was telling to Jeannie, though, is there are sites that were initially part of our study where they had such good results with this procedure, where they are now sending their patients for sympathectomy first. But that's India, that's not the United States. We have guidelines that we go by, and not everything is investigator driven. And so I think here we're looking at a randomized trial where we basically want to do this procedure after they have failed the first VT ablation, and sort of kind of start off with maybe the AVID study group, and then walk back and see if this procedure has any benefit earlier. we have had some difficulty with funding that trial because device companies don't want to fund the study. They don't want to put in less defibrillators, right? And NIH currently is sort of in a mode where they only want to spend a limited amount of money per patient, but this is a surgical procedure and it requires multiple sites. You don't have a sympathetic patient who needs sympathectomy coming in every day through the door like you do with STEMIs. And so it's kind of, in that regard, we've kind of run into some funding, and I've kind of try and talk around and see if there are other sources we can go to where we can get funding to at least do sort of a small design study of 100 patients where we randomize them. But we do need a randomized trials. And I'm a big fan of like just not misinterpreting retrospective data.
Sure.
Yeah, so as another contrarian in
Oh my.
So we're stepping up the contrary.
That's fine.
that's why we brought him. So regardless of what you think of the sham stenting study, it certainly did start a conversation.
Absolutely.
What about the sham sympathectomy study?
So,
Anybody thinking of doing that?
well, I think that would be even harder to do. But to take a patient into the OR under general anesthesia, put up all the lesions, and then close and say, have a nice life, even though you're having 10 ICD shocks in the past 6 months. But I do think you have a valid point. Having said this, I think this trial is slightly different because VT is not like, I feel better. It's a much more quantitative, hard endpoint. I had a shock yesterday, and I can interrogate your device and show that that wasn't in your head, right? So in that sense, although I firmly believe in sham studies, I'm not sure that you could potentially ethically justify this procedure. And also, I'm not sure that you necessarily need to. It's a much harder endpoint. And I think that maybe for the stent studies, it would be nice to follow those patients up, 4 years later, 5 years later, 10 years later, and see who died.
I have Rob's question. Yeah.
Okay, awesome.
Arun.
Nice talk. What are the hemodynamic consequences of sympathetic denervation?
Oh.
Do you see
Good.
hypotension?
So that's a really good question. So remember, these patients generally, when they're undergoing general anesthesia, right? So in a patient whose EF may be like 20 to 30%. So certainly perioperatively, they require pressor support. A lot of them do. I would say that 90% of them are off their pressors by 24 hours, right? That need for pressor support is much better if you send them earlier. If they come in after their first ICD shock after a VT ablation, than if you wait till they're in the CCU with incessant VT. But generally, I would say in our study of 121 patients, about 5 to 10% required pressor support beyond 24 hours, but most of them were off within 48 to 72.
And how about long term?
Nothing. Long term, it's great. It's afterload reduction. You can potentially cut down on their ACE inhibitors a little bit. There isn't a great blood pressure drop, but there is maybe a 5 to 10 millimeter of mercury.
Static hypotension.
No, because remember, you didn't take everything out. The middle cervical is still intact. I mean, all really this procedure does is kind of give things a nudge in the right direction. It's not denervating the sympathetic nervous system from the heart and the blood vessels.
So I have a question real quick, sorry, Lyle. So as somebody who's tried to bring sympathetic denervation or ask the surgeons, there are no surgeons in the room, right? I'm a surgeon's brother, so that's the only thing. So back here somewhere probably. But so one of the challenges is getting them to take enough of the stellate ganglion. So they're nervous, right? They don't want to cause corners. They don't want to cause a terrible complication. So if you don't take the correct amount, if you don't take enough of the stellate ganglion, could you be hurting the patient rather than just not helping them as much?
I don't honestly think beyond sort of the skin sensitivity changes and that changes in sweating that you're not hurting the patient by taking less. You're just not necessarily giving them all the benefit that you can. And what I tell our surgeons is a half, then usually I end up about a third. So, but the more they do, the more comfortable they become. And once they see that, the ptosis is really not as big of a deal, right, they're willing to take more. So it's just a matter of just kind of getting the treadmill started.
Lyle.
Wonderful talk, and thank you for presenting. presenting it in a way that even I can understand. I was going to ask what Arun asked as far as blood pressure, but the other thing I was thinking, do you do, and this may be why people with class 3 and class 4 don't do as well, but have you run into instances where you've had patients that don't tolerate single lung ventilation to do this, and then how do you address that?
So we don't offer this procedure if they have severe COPD, severe pulmonary fibrosis, something that suggests that they wouldn't be able to offer single lung procedure. But for the most part, we've been able to offer to a lot of our patients. There are very few patients that fall into the category of can't tolerate single lung. What we do is we tell our surgeons to start with the left. There's a lot more data on taking out the left cardiac sympathetic chain than there is currently on the right. The right was really kind of something that we came into in our lab and have seen that it does, help removing it, and that stimulated and does cause problems. And so we've been encouraging people to do it. But we tell them to start with the left, single lung inflation of the left side, and then if they need to abort, they've at least taken one side, right? And they can come back. To answer Arun's question, we had about 10 patients, and this is something that one of our attendings, Olu, is now looking at, that had autonomic testing pre and post cardiac sympathetic denervation. So we had them go through a tilt and Valsalva maneuvers and all of that, and for them, their responses were actually normal. The place where they don't have a normal response is where you make them do a math test. Pre there's cardiac sympathetic denervation, if they have to count by sevens and subtract by sevens backwards, their heart rate shoots up and they get all stressed out. Post cardiac sympathetic denervation, that response is blunted.
Good for public speaking.
Yes.
Well, that was really impressive talk.
Thank you.
I'm curious about how you could make renal denervation more effective, procedural imaging, intraprocedural cardiac ultrasound, and then you had mentioned the potential of combining it with an ablation.
Yeah.
You can use the same catheters, and it has the ancillary benefit if you don't need to get this surgical call.
Right. So I think right now, people are not looking at good endpoints, right? That's the problem. And actually, if they had looked at it potentially before they had all their clinical trials, they could have kept the whole field's door open. But I think that we've just used the gross blood pressure response so far for stimulation, pre and post each. So we do basically like 4 ablation lesions at low wattage, and then we stimulate again to see if we get the same blood pressure response. But I think that's a really important question. Like, why aren't we doing potentially sympathetic nerve studies that we use, in the heart, on the kidneys to see if, but they may not have the resolution. So we're still sort of in limbo as to what's the best way. Like, could we sample our renal artery neurotransmitter levels, right, pre and post ablation to see if there's a decline? Could we give a sympathetic stimulus of some sort and then look at that norepinephrine release profile in the renal arteries? So all of those things are kind of areas of research, and different people are looking at them, but currently there's nothing sort of that's coming on clinically. What the companies are working on are just kind of developing better catheters, different catheters to try to address this problem, but it doesn't address the question of an endpoint. When am I done ablating in the renal artery?
Thank you, Marmar.
Thank you.